It's my joy and pleasure to have been given the task to summarise in the very last talk of the day the lymphoid highlights from BSH, which has been very good for me. It's ensured I've gone to every session, taking note of what's been presented. And there's been a real spread of data shown actually from the lymphoma side, from the high grade, low grade and CLL. We've had a couple of encore presentations of really good data that was presented on the Gallium trial at ASH. So that's allowed us to look at indolent lymphoma, well, particularly follicular lymphoma data has been presented. Patients who are treated with obinutuzumab chemo versus rituximab chemo, and Robert Marcus presented that, showing this clear progression-free survival advantage at 3 years. A lot of debate as to how that will translate into clinical practice, a lot of discussion about toxicities, particularly in the bendamustine arm, that has recurred through actual different sessions. Christiana Pott showed us the deeper molecular MRD analysis, which across the different chemotherapy backbones shows that the addition of obinutuzumab does seem to deepen the remission, so more patients are achieving a molecular MRD negative remission with that antibody. So very interesting. How that's going to impact on our practice at the moment is uncertain, but we're going to have to see how that data plays out and see what the regulatory authorities think of that. There's been a lot of other good discussion, some of the younger investigators coming through presenting their data. There was a great debate about the double-hit lymphomas and should we be testing for these, should we not, does it impact on our practice, and a lot of the themes that we wrestle with quite commonly in the clinic. We can do all sorts of tests, whether it's a molecular test, a PET scan, we can identify good players, bad players, but if we can't do anything that actually changes the natural history, if we can't improve that patient's outcome, should we really be doing tests that aren't going to translate into difference of management? And that's a big theme for discussion across the board. So what else have we had? We've had data on Hodgkins. There was a great presentation from Anas Younis, a tour de force of some of the newer Hodgkin data. He naturally concentrated on the developments of brentuximab, nivolumab, touched on some of the new trials coming. I must say a bit of a plug here, where we've got a poster from the east of England looking at our escalated Birkhoff data in reference to our ABVD data, which is a bit of old-fashioned chemotherapy, but we've found some pretty impressive and for us quite convincing data supporting the use of these more intensive chemotherapy regimens in the poorer risk patients. But that data is here for presentation and due for submission for publication. There was some other Hodgkin's data on posters. There was some allogeneic transplant data from Leeds, which I think reminds us how tough it is with these really difficult Hodgkin's. But yeah, 50–60% of patients can get long-term cures with allogeneic transplant. So that was certainly good data to see. There were some other posters, actually, some good work from King's looking at post-transplant lymphoproliferative disorders, looking at their patients post-liver transplant. Interesting, splitting out their data by rituximab use and non-rituximab use, but a real very early drop-off in their curves. And I think that reminds us, all of us who treat post-transplant lymphoproliferative disorders, that the early mortality, particularly these sicker patients, liver transplant, use of chemotherapy, then a lot of patients unfortunately do succumb to their disease or consequences of treatment and complications early on. So that was quite sobering, looking at some of those Kaplan-Meier plots. So then away from lymphoma, there have been some interesting CLL data sets. Martin Dyer had some early phase data from his trials looking at the Gilead 4059 drug combined with idelalisib in indolent lymphoma and CLL. Interesting data, a drug that we would love to see develop further and come into the clinic, but we'll have to see how that develops. And of course, the CLL data, I have to plug the CLL forum data, sorry, but we've presented our poster of updates there, and really interesting stuff from our perspective. We think it's quite telling, some of looking at the reasons to why patients stopped Ibrutinib therapy in the first year and beyond, and looking at their outcomes in patients who relapse beyond the first year, particularly those who've had access to venetoclax, and whether that's going to have longer term impact on their outcomes. So across the patch, a lot of interesting things in the world of lymphoma and CLL, and hopefully this will go down well in the summary talk I'll be giving in an hour or so's time.